Hello, everyone, and welcome to today's webinar, ProTube, Success Stories at Hospital Clinic of Barcelona. My name is Kevin Flug of LabRoots, and I'm going to be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Inpeco. To learn more about our sponsor, please visit www.inpeco.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You can also use the Ask a Question box to let us know if you're having any difficulties seeing or hearing the presentation. I would now like to welcome both of our speakers for today's webinar, Dr. José Luis Bedini, Core Lab Head at Hospital Clinic of Barcelona, Associate Professor of Biochemistry and Molecular Biology at the University of Barcelona in Spain, and Ricardo Mellis, Regional Distribution Manager, East Europe for Inpeco. Gentlemen, we're so thrilled that you have joined us here today. We are greatly looking forward to your presentation. And with that, I'm going to turn it over to Ricardo to start. Ricardo, whenever you are all set, you can begin.
Thank you, Kevin, and thank you all for joining us today. So first of all, this will be a live event, so we apologize in advance if any issues arise. So on behalf of Inpeco, it's my great pleasure to welcome you to this webinar and to have with us Dr. José Luis Bedini, who will share his first-hand experience with the Inpeco ProTube, highlighting how the solution has helped address key pre-analytical challenges at Hospital Clinic of Barcelona. To begin, I will provide a very brief overview of Inpeco, who we are, and what drives our mission. Inpeco's journey starts with a clear vision from our founder, Gianandrea Pedrazzini. So to improve patient safety by reducing human error in clinical diagnostics through automation. In the early 90s, he really introduced the concept of total lab automation, an approach that has since shaped the industry and with many of its original principles still in use today. So nowadays, Inpeco stands as a global leader in total lab automation, delivering advanced solutions worldwide, both directly to end user and through our network of partners. What Inpeco does: develop and manufacture automatic technologies that enables healthcare institutions to control every step of the diagnostic process. Our mission is to support laboratories in improving efficiency, quality, and patient safety through automation, traceability, but also continuous innovation. Today, our solutions are installed in more than 2,800 laboratories worldwide, and we are present in over 78 countries. So this extensive global installed base provides us with strong experience, deep expertise, and a comprehensive understanding of market trends and dynamics. Today, laboratories and hospitals are facing constant and increasing pressure. So an aging population is driving a higher demand for diagnostic testing, while the growing prevalence of chronic disease requires more and more frequent and continuous monitoring. At the same time, the shortage of skilled personnel make it more and more challenging to manage these rising workloads. In addition, financial pressure continues to grow, driven by declining reimbursement rates, and workflow are often still fragmented in the hospital, resulting in operational inefficiencies. Finally, patient expectations are evolving. So with a growing demand for faster, more accurate, and more personalized services. In summary, laboratories and hospitals are more and more being asked to do more with fewer resources. So the key question now is, how can they achieve this? At Inpeco, we choose to address this challenge by adopting a holistic approach to the entire diagnostic process. This means bringing automation and traceability across the entire workflow, not only within the laboratory, but also by optimizing everything that happens before it, which today represents the most critical phase, ensuring that every step is fully under control from patient identification to result delivery. All of this is made possible today through the combination of our solution, ProTube, for the pre-analytical phase, and our new open automation platform, FlexLabX, within the laboratory. So with this overview in mind, so I'm now pleased to hand over to Dr. Bedini, who will share his experience at Hospital Clinic of Barcelona. Thank you.
Good morning. First of all, I would like to thank Inpeco for inviting me to share our experience with all the people attending the webinar. In a few seconds, I will share my screen. You can see my email address at the right bottom of the slide, jlbedini@clinic.cat. Please feel free to send me an email to ask whatever you need or to visit your lab if you are in Barcelona. I want to start sharing some details about my hospital. Hospital Clinic is located right in the middle of the city of Barcelona, and this is one of the problems that we have, that we don't have more space to grow. So then this is the location of the hospital, and the hospital is a very old building from the end of the 19th century. And this is the problem that we have, that we don't have more space. We are totally surrounded by the city. When the hospital was open, around the hospital, there was nothing, just farmers and fields and forests. And now you see that the hospital is totally surrounded by the city. The hospital is not just one site. In fact, we have three hospitals belonging to Hospital Clinic. One is Maternidad campus for mother and child, ophthalmology, and day surgery. Then we have the Plateau campus that has been integrated into clinic in the year 2021. And the Villarroel campus, the main site, where the lab is located. And overall, we have something around 900 beds. Each of these hospitals, we take care of 600,000 people around the city of Barcelona. The left side of the city belongs to us as a community hospital, but we are also the reference hospital for the whole region of Catalonia for some pathologies, and even for some conditions, we are the reference hospital for the whole country of Spain. The three sites, they are more or less within a distance of 3 kilometers one from another. So we are connected by transport system to send the samples from one hospital to the main hub at Clinic Barcelona in Villarroel Street. This is the hospital, as you can see, as I mentioned, totally surrounded by the city. The green area is the hospital itself, and the yellow area is the University of Barcelona, the Faculty of Medicine. We are a university hospital, a third-level hospital, which is the maximum complexity of hospitals in Spain. And these are some data from the year 2024 about our activity in terms of number of beds, admissions, outpatients, ER visits, surgical procedures, the mean length of stay, the number of employees, and the total budget, which is over 750 million euros. Regarding the labs, all the labs in our hospital are integrated in an organization that is called Biomedical Diagnostic Center. We call it Centro Diagnóstico Biomédico, CDB. That includes all the labs belonging to our hospital. We are almost 500 employees in all the labs. The budget is around 60 million euros. This is the total space occupied by the labs. This is the total activity that all the labs perform together. And the important idea is that the core lab performs almost around 90% of this total activity in our hospital. But after reviewing this few data of the clinic hospital, I want to start the real matter of my presentation, which is our experience with ProTube and why we decided to start to work with ProTube. It has been a challenging project to improve the patient safety. This was the main idea behind the project of ProTube installation in our hospital. And all the idea is based in our objective to reduce errors in laboratory medicine. There is an ISO definition for laboratory error. This is the official definition. That is a failure of plan action to be completed as intended, or use a wrong plan to achieve an aim occurring at any part of the laboratory cycle. And this is probably the most important idea that I want to share with you today, any part of the laboratory cycle, from ordering examinations to reporting results and appropriately interpreting and reacting them. And that's the problem. What does it mean, any part of the laboratory cycle? It means the total testing process. So then the combination of all the processes and procedures with all the interactions with the personnel and the available technology involved in the testing, from the moment that the patient access to the testing system to the moment that the action is taken by the health professional and exerts an effect on the health outcomes. Sometimes we think about the total testing process only within the lab wall. And this is not the right idea. We need to think about the total testing processes considering the whole process from the very beginning to the real end. And this definition is closely related to the brain-to-brain loop described by Lamberg that considers all the steps of the testing cycle. The brain-to-brain loop considers all the steps of the testing cycle from the initial clinical question of the physician ordering the test until the information is available from the laboratory. Many of you have seen this brain-to-brain loop image, but I want to review it today. Everything starts with the physician brain and the need of a test for clinical decision, and then it's the ordering, the identification, the collection of the sample, the transportation, the preparation, the analysis, the review and reporting, and the interpretation of the results from both the laboratory's professional and the physicians to take the right decisions, the right clinical care to attend the patient. And here we will use this image to talk about laboratory errors and to consider where the laboratory errors can occur. And that's the point, that errors can occur at any step in any phase of the total testing process. It can occur at the pre-analytical phase, at the analytical phase, and in the post-analytical phase. So if we review again the brain-to-brain loop, and we mark in green all the steps that occurs in the pre-analytical phase, you just see that many of them are in the pre-analytical phase. Only analysis is related to the analytical phase, and we have two steps of the Lamberg brain-to-brain loop that are related to the post-analytical phase. The problem is that the last years, or always, I would say, to reduce errors, we have long focused our attention in the quality control methods and quality assessment programs that deals with the analytical phase. We have worked a lot and we have achieved a huge success reducing the analytical errors, working with the quality related to the analytical phase. Automation, improved technology, aside standardization, information technology, and better trained staff has also contributed to reduce the prevalence and magnitude of the analytical errors. Consequently, and as I have mentioned, the rates of analytical errors in the last decades have been dramatically reduced. Here you have some studies from different authors, and you can see how big is the decrease in analytical errors in parts per million. But the problem is that it has also widely demonstrated the quality in clinical laboratories cannot be assured just focusing on pure analytical or technical aspects. And probably all of you know Plebani. Plebani has been the father of the studies related to the pre-analytical errors. Many studies have demonstrated that pre- and post-analytical phases of the total testing process are more prone related than the analytical phase. In these studies, you see that pre-analytical errors stands for something around 70%, post-analytical errors more or less 20%, and the rest is analytical errors. So then we have been invested a lot of efforts and time reducing the analytical errors, but we need to work more closely and with more effort in order to try to reduce the errors related to the pre-analytical phase. The thing is that many errors in the total testing process are called laboratory errors, even when these may be due to action taken by others involved in any step of the testing cycle, physician, nurses, or poorly designed processes that are beyond our responsibility. So we are suffering some errors related to the total testing process that are not related with our responsibility. It's an extra laboratory responsibility. But we need to work to correct that. That's important. So the unique framework for considering where mistakes can occur in the lab testing process is the brain-to-brain loop in the total testing process. So if we mark in blue the extra laboratory source of errors, you can see that we can find errors in the ordering, identification, collection, transportation, and interpretation. Those errors are related to the extra laboratory steps of the total testing process, and these processes are not our responsibility. And only some part of the preparation, the analysis, and some part of the review and reporting are intra-laboratory processes. Thinking about patient safety, which is the most important thing, errors must be identified and fighted irrespectively of where are generated, intra or extra laboratory, and whether the error is caused by a laboratory professional or by a non-laboratory professional. The consequences of the error are the same independently of where the error has occurred. To distinguish errors generated in the pre-analytical and post-analytical phases that occur beyond the limit of the lab, other two phases were defined. And that's important because some of the pre-analytical errors can occur in the lab and some of the post, but some of them occur out of the lab. That's why we define, and Plebani was the first one, the pre-analytical steps. Initial procedures performed neither in the clinical laboratory nor, at least in part, under the control of laboratory personnel. Test requests, patient and specimen identification, sample location, handling, and transportation. All these processes are pre-analytic and occurs extra laboratory. That's why now they are called pre-analytical steps. In the same way, we can define the post-analytical steps. Those final procedures performed outside the laboratory, like receiving, reading, or interpreting the lab information for the patient management. Again, if we display this pre-analytical phase and this post-analytical phase in the brain-to-brain loop, we can see that in the pre-pre, we have these green boxes: ordering, identification, collection, and transportation. Then we have preparation, that would be pre-analytics that can occur at least in some part within the lab. The analysis, that is an analytical phase. The reporting, that is post-analytical phase, and interpretation, that is post-analytical phase. If we search for studies that have evaluated the errors that are produced in these phases, we can see something that is really a nightmare, I would say. More than half of the errors, 56% of the errors related to the total testing process, occur in the pre-analytical phase. So it's out of the lab and it's out of our responsibility. So then more than half of the errors. So that even we have been able to reduce the analytical errors to something below 1%, according to these studies, there is like 56 plus 23 for the pre-analytical and post-analytical, more than 3/4 of the errors that occurs in the total testing processes that occur outside of the lab. And I am really convinced that we need to be involved in the solution of this problem. Here we can see another approach from another author about the pre-analytical and pre-analytical errors that are between 46 and 68%. That includes sample condition, insufficient sample, incorrect identification, sample and handling transportation, errors in the analytical phase, and errors in the post-analytical phase and the post-analytical, like reporting, improper data entry, or the turnaround time. So it's clear, errors in the pre-analytical phase occur out of the lab and not under our responsibility. That stresses the point of the importance of interdepartmental cooperation in improving the quality of the specimen collection and handling. We need to work together with nurses and physicians in order to correct the problems related to the pre-analytical phase. And that's why we decided to start the ProTube project. Once we discovered these numbers, the importance of the pre-analytical phase, we decided together with our hospital administration that was time to invest time and money and efforts to improve the quality in the total testing process. This is a challenging project, which is not easy, that is about patient safety, because if you provide a bad result for a patient, this affects directly to the patient outcomes. It's a challenging project also about quality. It's about information technologies and technology, and as I mentioned, is about cooperation between different hospital departments. Everything started in 2017 when I had the chance to visit Inpeco booth at the ACC meeting in San Diego, where I saw the ProTube for the very first time. And later on, they had a booth the same year in our national congress. We went to visit the booth together with my all the labs directory in our hospital, and we decided to start a project with Inpeco. The project started in 2018 with the arrival of the first ProTube units, and then we start a pilot in the Centro Diagnóstico Biomédico phlebotomy area in November 2018 with just few units of ProTube. Before deciding to start the installation of ProTube all around the hospital, we considered that it was important to test the ProTube system in our facilities with our patients and our nurses. The description of the pilot project gives you an idea about how challenging it was. It was a heterogeneous patient population because there we attend every day more than 1,000 patients. Being ambulatory and the hospital patients the more frequent, more than 950 patients on a daily average. More than 3,000 samples per day are collected. With these human resources, 21 nurses, 3 nurses assistants, 4 administrative, 1 health assistant, and 1 coordinator, and 21 phlebotomy booths. There has been many challenges to being able to adapt ProTube to our needs. We are a third-level hospital, as I mentioned. This is the maximum complexity levels of hospitals in Spain. So we deal with a lot of sample types, with more than 600 different sample types and more than 70 different containers tubes, and we need to codify all of them. We also have some special sample requirements to transfer to ProTube. We need ProTube to inform us when we need to keep the sample at the proper temperature or to protect from the light. So we need all advices in the screen of ProTube. Our label design is quite complex with many different requirements, like all the one that I'm going to show you. In every single label, we have the code of the tube. O1C is the serum for the core lab. Whole blood is O2C. Every time that you see the letter C means that is a tube for the core lab. Other letters indicates other destinations. So just seeing the label, we can know where the tube must go. This black band that you can see here in red indicates us that there is a priority for the sample. This black band is automatically printed when the order is created at certain origins and gives us information about the priority of the sample. We also have some codes indicating us a particular test that need particular handling, like CO2, for example. That means don't decap. Or we have, as I mentioned before, the L, like in the label on the bottom right side, the letter L and H, protect from light or ice. So these all requirements that we have need to be developed and need to be included in the ProTube software in order to be printed with the labels. Also in the hospital, we have over 250 ongoing clinical trials that requires many special conditions and additional tubes. We need to integrate ProTube with the queue management software that uses the patients for being attended at the phlebotomy center. So overall, we have been dealing with a high complexity project with a really, really difficult to define. The results of the phlebotomy pilot project with ProTube gave us a better understanding of ProTube. We really understood how ProTube works and how can we install ProTube later on in the different wards of the hospital. We gain experience to face next steps in the wards. We work together with Inpeco to improve the hardware and the software with a significant reduction of incidences. We complete a phlebotomy booth redesign. We need to adapt our booths to the use of ProTube, as you can see here on the slide with the device and all the things. We also introduce pre-analytical workflow changes to be more, I would say, more smooth to work with ProTube together with our usual workflow. We learn how to train future ProTube users. This is also an important thing. And then we go to the next step. In November 2020, after 2 years that we start with the pilot project, ProTube was fully operational in the phlebotomy area with 26 ProTube units. The problem was that at that time we were suffering the COVID pandemic, and we need to slow down the installation of ProTube in the phlebotomy center and also in the rest of the hospital. And that's why the next step, it doesn't occur until May 2021, when we start a pilot project of ProTube in some special wards. We select only 4 wards, one day hospital, and we gave them 9 ProTube units. So the idea was, once ProTube was fully operational in the phlebotomy area under our responsibility, when our nurses were happy working with ProTube, when the number of incidences was very low, then we decided, okay, now it's time to involve other wards in the hospital to install ProTube, and then we start with the deployment of ProTube in just these 5 wards with the pilot project. There were also many challenges in the ward pilot project. One is the project communication. When we work within our walls in the phlebotomy area, it was easy. It was our people, 21 nurses. Now the project needs to be communicated to all the nurses in the hospital. So this is quite a complex. This image is from one of the sessions that we did at the hospital to share with them the project. There is always a resistance to change the things. At that time, the nurses in the wards, they were used to do the phlebotomies by themselves without technological assistance. And at the beginning, it was not easy to convince them to use a new device. We need to train more than 3,000 ProTube users. So then this is quite a challenge. All the nurses in the hospital needs to be trained with ProTube. We also need to improve the hospital Wi-Fi network. And we need ProTube, in order to work, needs the Wi-Fi. We need to integrate ProTube software with the hospital information technology tools like the hospital information system and the laboratory information system. We need to redesign the mobile card. The original mobile card was too big. Our hospital, as I mentioned, is very old. We don't have a lot of space. We need to make the cars more small and more convenient to move around the patient's beds. Of course, we need money and the budget availability for the installation of the ProTubes. So in July 2024, we start after the pilot project. We start with the implementation of ProTube at the 3 hospital locations. In December 2022, ProTube installation was complete in all the conventional wards. We had 83 ProTubes in 76 locations. So then the number of ProTubes was quite big. And in May 2023, we reevaluated the needs. We noticed that some of the wards that we gave them just 1 ProTube unit, they need 2 of them, or we gave them 2 and they need 3. So we reevaluated the needs of ProTube. And this is the current situation right now at the hospital. In total, we have 108 ProTube in 79 wards, including the 3 hospital sites, 81 at Villarroel, 12 in Maternidad, and 15 in Plateau. We have 29 ProTube in the phlebotomy center, and we also have 30 ProTube in external locations, like external customers. This is an important thing. Once we notice the benefits of ProTube within our organization, we have also provided ProTube to external locations not belonging to us. There are some family primary care centers that doesn't belong to the hospital, but they send us every day many samples. We also provided them with a ProTube unit. There are hospitals that has agreements with us that they also send samples every day. They also have ProTube units. So in total, nowadays, we have 167 ProTube units in total. The next step of the project that will happen this year is the ProTube mobile installation in our emergency department. In the 2 small hospitals, we also have ProTube in the emergency department, but they use the conventional ProTube, the one that you see on the left side of the image. But in our own emergency department, we are going to install the small ProTube that you see on the right side of the slide. This is the mobile ProTube. It's like a phone mobile that you see in the right hand of the nurse, plus a small Bluetooth printer that prints the labels. We are in the final steps of the designing this final step of the project, and we are going to start as soon as possible with the installation of this ProTube mobile in the emergency department. So the situation nowadays is 167 ProTube units and increasing. That means that is the largest ProTube installation in the world. What improvements we have achieved with ProTube? We have a total traceability except but for a few time for transportations, because I will introduce you right now also a new project of samples from origin end to end. So this is how it works now. Is we have the patients arriving at the phlebotomy center where they scan the order and the patient reception. We have the patient check-in in the phlebotomy booth, the patient checkout in the phlebotomy booth. These are two new steps that we didn't have without ProTube. We have removed this sample check-in out in the sample reception area, which is not needed anymore. So the samples that we collected in the phlebotomy area, it goes direct to FlexLab X, which is our automation systems, where the check-in is performed by the same track. I want to make a short parenthesis, and I want to talk you about FlexLab X, that is our TLA solution. And we decided to install it because we had a previous and satisfying experience with Inpeco and Siemens, because we work with up to 10 years. It was the first installation worldwide. We start in July 2024, so almost 2 years ago, we installed the first FlexLab X in the world, because it has a flexible design that allows us to adapt to the changing needs of the lab, because it helps us to save space, as you will see in a couple of slides, because we have achieved important improvements in workflow using FlexLab X, because it's an open TLA to connect analyzers from different vendors, because we have a full sample traceability. We can know where every single sample is located at every single time. And because, and that's why I want to talk about FlexLab X, because we are moving our concept of automation and workflow from total laboratory automation to total testing processes automation. So then the idea is to merge information coming from ProTube and information coming from FlexLab in order to manage and to integrate all the information coming from the total testing process. And because we want the best of both worlds. From one side, we want to keep the trusted experience that we had with Inpeco, but we want to integrate also the fresh innovation that comes with FlexLab X. And that's why our idea was to install FlexLab X as soon as Inpeco and Siemens offers us to be pioneers for the first installation in the world. This is one of the benefits that we have achieved with FlexLab X. You can see here the footprint that was in the layout of the hospital with Aptio. This is the footprint with FlexLab X. You can see that there is a significant reduction. In fact, the footprint reduction is around 70%. The previous track route was 108 meters. Now it's 71, with a total reduction of 37 meters. So this is the important message, that now with less space, we have a space to connect other analyzers. No space was available on Aptio. So then now we have no connections available to install new analyzers. Another important achievement is that we have improved our workflow to manage samples with priority. And here you can see a significant reduction of the turnaround time, 5.3 minutes reduction. That is almost 10% just installing FlexLab X, which is really important for us to manage samples with priority. Another important and significant reduction is about the noise. There is a reduction of noise around 30%. In terms of decibels, 30% is the right number, but in terms of noise perception, it's much higher. Now, the atmosphere in the lab is more relaxed and quiet, and this is very important for us. And this is a real video about the lab. This is also something that I want to share with you. You will see that the lab is very open, and there is a lot of light. There is a lot of space to move around. And now you will see one of my technicians, Christina, that will load some tubes to the track. You can see that the atmosphere is very relaxed in the lab. And this is a huge change for us. So then she's dropping the tubes in the bulk input module. So going back to the ProTube project, after this short description about the FlexLab, the thing is that now we have traceability in almost all these things, including ProTube and FlexLab X. We have traceability in the ordering with ProTube, identification, collection, preparation, analysis, and review and reporting. We have traceability. And the only point that is out of our control for traceability is transportation. But now, of course, it's impossible to have traceability in these red steps. But now we are working together with ProTube to also have traceability in the transportation. And this is the project that I want to share with you because we are in the final steps. In fact, we have started a pilot project with one of the family care centers that starts with sample preparation at the collection point, sample transportation with the courier route, and the sample check-in at the clinical laboratory. The first step is the rack pairing at the start of each rack. So at the collection point, the nurse that will start the phlebotomist is reading the label on the rack and is starting the pairing. So all the patient identification and sample collection with ProTube is linked to this particular rack. So here you can see that she is pairing the tube checkout and the automatic pairing with the rack. So all the tubes that you place in the rack are paired to this particular and previously defined rack. And is also when she ends to load tubes in the rack, she's reading the rack QR to start the transportation mission, and also is linking the rack to the container So we have linked with ProTube the tube with the rack and with the container. Now, when the transportation responsible comes to the lab, we also pair the identification of this person to the container. And then when this person arrives to the lab with this small black device you can see on the top of the drawers, we link we perform the check-in with RFID to the arrival, and then when we receive the samples in the lab at the destination, we can read the time and temperature, and we know that this container contains this particular rack and these particular tubes. So this is important. We have been able with this project to complete the traceability in all the processes of the total testing process. Nowadays, with ProTube, another benefit that we have achieved is that we can easily sort the samples in the phlebotomy booth. We put the samples for ProTube that has the letter C, as you remember, in the left rack, and samples for other destinations in the right rack. We are simplifying the delivery of samples to the core lab. We don't need to go anymore to the sample reception area. So then we have been able to reduce the turnaround time in more than 33 minutes, 61%. It's very simple to train nurses. Nurses in the hospital, they need a training that is something around 5 minutes, because it's mainly just follow the instructions on the screen. There is a significant workload reduction in the sample reception area, because they don't need to check in samples anymore. And of course, there is a significant reduction of pre-analytical errors. We have performed many studies about that, but I want to show you the first one that we did in 2020. You see here wars working without ProTube from July to September 2020. The number of orders received, the number of incidents registered, more than 4,000. So 11% of the samples had pre-analytical errors, being sample not drawn, previously submitted sample, or surplus tubes the most frequent. And after the implementation of ProTube, comparing the same works, the number of incidences were reduced, and now is something around 1.8%, being with a significant reduction of all the errors. We have later studies that demonstrates that currently we are below 1% of pre-analytical errors, which is a significant reduction compared to 11% that we had before ProTube. This is this is one of the later studies that we have performed, and you see here that we are also below 0.5% errors. So this is important because now with ProTube we have been able to fix all these problems: incorrect sample, incorrect identification, and sample handling and transportation. How does ProTube work? So then now I have shared with you the project, the benefits of ProTube, being turnaround time, the significant errors reduction, the most important. But probably you have never seen ProTube working. I have these videos. We scan the barcode that has the patient. So all the data from the patient are being loaded from the LIS to the ProTube. You see that for this patient, we need all the tubes that we have in the tablet. So the nurse has the information to collect the right tubes, and she is placing the tubes in the ProTube system. The system is able to read the color cap, and it places the right label to the right tube. If you put a wrong tube, a tube that is not needed, since the ProTube system is able to read the color cap, this tube is discarded. It will appear a warning on the screen telling that I don't need this tube, and this tube is sent out by another place in the ProTube. In the next step, here you see that when all the tubes have been collected, that you see, and then the screen in the tablet, it changes, and you have the filling order. So the important thing is that ProTube tells you both the tubes that you need and also the right filling order. That's why the training of the nurses is so short, because they only need to follow the screens. And another important thing is that after the collection of the tubes, the nurses check out the tubes. So then the tubes that have been, you see here, the label is reading below the ProTube, and that means that the checkout has been performed. So we have all the information. We have the check-in, we have the checkout. That's why we have been able to eliminate the checking process in the sample reception area, and the tubes collected in the phlebotomy center goes direct to the core lab. So our evolution from the very beginning compared to the workflow without ProTube is that in the past we were working with total laboratory automation, and we managed some part of the pre-analytical phase, the analytical phase, in some part of the post-analytical phase, and now we have moved to total testing process automation, TTPA. And now we have information about pre-analytical phase, pre-analytical, analytical phase, and post-analytical phase. And that's important. If we go back to the brain-to-brain loop, you see here all the steps in the project, and this is what we have achieved. No, this ordering and interpretation project, it will never be under our control. But now with ProTube, we can trace, and we can have all the quality information for identification, collection, and transportation. With FlexLab, we have the analysis and preparation. With our LIS, we have the information about review and reporting. So now we have information and traceability about total testing process automation. That's, for us, the most important part of the project, that now we can control all the process that belongs to us, even if it occurs outside of the lab. I have 2 minutes because I want to share with you another project that we are working with Inpeco. It's called IBIS, that stands for Inpeco Business Intelligence Service. And since Now we have all the information coming from FlexLab and all the information coming from ProTube. Inpeco is working in a cloud-based intelligence service that provides real-time KPIs, trend analysis, and root cause insights, such as the total turnaround time, sample quality indicator, modules utilization, bottleneck detection, across the complete total testing process. So this is a new tool that we are working with them in the final design that will provide you information about the total testing process. You will have, like here in this slide, tube tab description, tubes with repeated tests, with tubes with reflex tests, sample integrity, all the control of the total turnaround time from the phlebotomy until the results reporting. You have all the information that you need. You see here, pre-analytical, analytical, post-analytical, storage, everything. So then that's for us something unbelievable 10 years ago, because this is something that we have asked for many times to different companies. And now we are able to send, like the Artemis 2, we can send rockets to the moon and back, but in the lab, it's impossible to know TAT in real time or to have all this information that now EVIS will provide us. So then we are very happy with this development. Also, I want to share with you, and these are, we are reaching the final slides, a survey that we conducted with our nurses. It's important because sometimes we work with new projects, but we need to take into account, as I mentioned, this is a cooperation project between nurses, physicians, and the lab. We need to know that they are really satisfied with ProTube. And here we send, this is a high rate of answering the survey. We send them some statements about ProTube, and you will see that they totally agree in a high percentage. No, facilitates correct and unequivocal patient identification, 81% totally agree. Provides information about tubes required and sample special characteristics, 84% agree. Avoid samples contamination, 79% agree. Avoids identification errors, 81% agree. Total and immediate sample traceability, 75%. 86% totally agree with prevent order duplicity. 80% automatic labeling, but you see it is 80% agree. So here, no, it's incredible because they are very happy with the results of the implementation project. In fact, then this is a real quote. When we start installing ProTube at the pilot wars, some of them they didn't want to work with ProTube, but later on they cannot live with ProTube. And in fact, other wards not using ProTube, they came to us asking for a ProTube. I have seen the ProTube unit in another ward. We also want this device for us. Okay, here also the ProTube card is ergonomic. So then all the results all satisfy a lot the customers. These are a few real testimonials. They are in Spanish, but I have translated to English.
Hola Loli, ¿qué tal? Buenos días. Mira, te quería decir que en esos días, sacando una analítica del ProTube, pues que el problema que tenía siempre que cuando son esas analíticas así muy largas que se repiten los tubos y que no sabes cuántos tubos van, con el ProTube pues nada, excelente. Me ha ido muy bien porque te lo define y te dice cuántos tubos son exactamente y qué tubos son, y el color también es bueno porque a veces te pide que es un rosado claro, el tubito ese que es rosadito claro, el azul. Bah, yo estoy encantado con él. La verdad que me siento más seguro sacando las analíticas, pregunto menos y voy más a la fija. Voy directo a sacarlas y sin miedo de que me equivoqué.
So to summarize, this is a quote from Mario Plevani, about good samples. Only good samples make good assays, and only good reports make good laboratory information. To ensure that the answer to a clinical question is reliable laboratory information, and to obtain accurate laboratory results, 5 rights should be observed in the pre-pre-analytical phase. Right patient, right time, right test, right sample collection and handling, and right transportation. But I would like to add that the problem is that bad samples make bad assays make bad results, and bad results make bad reports and bad laboratory information. Too often, we don't know which are the wrong samples. We don't have the tools to detect them because the error occurs outside the lab. So instead of 5 rights, we have 5 wrongs. Wrong samples, wrong assays, wrong results, wrong reports, and wrong laboratory information. And consequent is poor quality care. Poor quality care, and this is also an important quote, is an overlooked epidemic that significantly threatens global health. The consequences of poor quality are far-reaching, affecting health outcomes, mortality, economic stability, and patient trust. And to reduce adverse events and improve patient outcomes, healthcare organizations must strengthen safety protocols, enhance reporting and accountability mechanisms, invest in workforce training, foster a safety culture, and leverage technology and innovation. And this is what we have done. We have leveraged technology and innovation, and we have focused our efforts in improving the quality outside of lab. In summary, and bearing in mind the recent Artemis mission, and using another film about the space that tells an epic drama of adventure and exploration, I think that we have moved to an epic drama of innovation and quality. And we have changed the focus from the analytical phase, that is something that we have fixed over the last decades, to improving the quality in the pre-pre-analytical phase, where the majority of errors occur right now. And I think that this is the real point that we need to work together in order to improve the quality that we provide to our patients. Thank you for your attention, and I will be happy if you have any question to answer.
Well, thank you very much for your informative presentation. And as Dr. Bedini just mentioned, we're now going to start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just type your question into the Ask a Question box and click Submit. We'll answer as many of your questions as we do have time for. And Dr. Bedini, we've already got a lot of great ones coming in, so we're going to jump right in there. First question that came in does ask, now that you have achieved such a high level of sample security, what additional operational improvements have you observed within the laboratory and, more broadly, in other hospital departments that rely on the efficiency of the core lab following the implementation of ProTube?
Yes, I think that in fact the benefits of ProTube are more related to departments outside the lab, because of course when we collect wrong samples, the bad result is produced in the lab, but the consequences of this bad result are for the patient, and the patient are located in the wards. So the benefits are for the patients, and this is important, and for the hospital departments. The nurses, for example, when they have a young nurse coming to work for a substitution in summer, before ProTube, they need to train the nurse 2 or 3 days. Collecting samples is not easy for a young nurse in the ward, because they need to know which is the right tube for the right depth, the collection filling order, everything. And now with ProTube, they can train nurses in few minutes. So I think that the ProTube is an initiative coming from the lab, but to benefit wards and patients. And that thing is important. The commitment of the lab to improve quality, helping nurses to collect samples in the right way, reducing in a significant way the errors, as you have seen in the slides, and of course preventing mistakes that can harm the patient.
Excellent. Thank you very much. Your project demonstrates strong collaboration across multiple departments. In your experience, what was the key factor that really made implementation successful?
Communication. The only way to succeed in such a complex project is communication. You need to be able to convince the hospital managers, the nurses, the head of nurses of the benefits of this project. And of course, you need a leading person from the lab side. In our hospital, in our story, that has been the head of nurses in the laboratories. Miss Jaén is her name. She's brilliant, and she alone she make all these meetings. She informs the nurses. She came many mornings at 5 a.m. to teach the nurses. So you need both a leading person and a strong communication project with the wards in order to achieve this cooperation from them.
Oh, excellent, and that's a great feedback with that. Given the current pressure on hospital budgets, implementing innovative solutions can be challenging. What would you recommend as the first step to start a conversation with hospital management or procurement when proposing solutions like this?
Quality is the main thing. It's all about quality. Quality, but I would say, in fact, it's all about non-quality, because when we have errors in the pre-analytical phase, we will occur in non-quality costs, more phlebotomies, bad diagnoses, other complementary tests not needed, or explorations. It's difficult to let the managers understand that this is about quality and about non-quality. Everybody knows very easily the costs of quality, because it's related to quality controls, it's related to processes that you can see, but it's very much difficult to evaluate the cost of non-quality. The cost of non-quality sometimes is the health of the patient, and it's very difficult to quantify in euros or dollars, which is the cost of the non-quality. So I will face the manager. In fact, that we did in our hospital. We convinced the manager of the hospital that this was a project of quality and non-quality. The quality that you can see and the quality that you cannot see. And non-quality has cost that you must prevent, because sometimes it's a cost not related to money, but it's a cost related to health.
No, that is phenomenal suggestions. I really like that. Thank you very much. Thank you again for your time today and your important research. I also want to thank LabRoots for hosting this event and for Inpeco for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and their interesting questions that we did not have time for today, and those submitted during the on-demand period will be followed up by either Inpeco directly or Inpeco's local representative. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So once again, thank you all very much for your time today. And until next time, everyone, goodbye.
You can see my email address at the